meeting is being recorded.
Hello.
This meeting is being recorded.
Good afternoon, everyone.
Good afternoon.
Good afternoon.
Happy New Year. This is our first meeting online at this webinar, the first for 2022. And today I'm really super excited for many reasons. One is that the presenter is my brother, Dr. Oyekunle Ayonrinde. Secondly, the moderator, my sister, Dr. Takom. And I also like to thank Dr. Rifadi for bringing the two of them together today to make this presentation and to moderate this presentation. I'm also excited because I recall in the early 90s when we were doing a neurology posting in youth, when we see children with cerebral palsy and when there are no complaints, we simply write, like Kunle reminded me yesterday or 2 days ago, no fresh complaints, continue for physiotherapy. But we now know that there is more we can do. So there are more things we can do for these children rather than just continuing physiotherapy. So I'm really excited that today we're going to listen to Dr. Ayonrinde. But before we start, in our usual manner, I'll just hand over to Dr. Mobolaji Lawal for a few words before we hand over to Dr. Takom to moderate. Thank you very much, sir.
Yeah, thank you very much, Dr. Iletu. I join you in, am I audible?
Loud and clear, sir.
Okay. I join you in welcoming Dr. Oyekunle Ayonrinde to this program. It's nice to see him and also the moderator, Dr. Ian Takom. I look forward to a very fruitful time this afternoon. I greet our elder, Dr. Ajeni Fuja. I acknowledge the presence of Professor Ofovwe. I don't know whether it's in Nigeria or it's in Sierra Leone or something. I also can see a few of our pediatric neurologists joining the group. So I've seen Dr. Salisu. So I think we are going to have a very exciting time this afternoon. Just by way of a general statement, I'm very pleased to inform everybody that our group is gaining more traction every day. Just back from PanConf last week, the level of enthusiasm and expectation is very high. And that means that we need to work harder in order to sustain this level of enthusiasm and expectation that every pediatrician has for this group. The immediate tasks that we have ahead now, if I can just mention them, is to register the organization, expand the content of our CME, maybe to CPE, professional development, in area of professional training and practice management, having consolidated on the clinical side. We will need to gradually introduce those ones. And also finally, now that the COVID-19 is gradually rounding up, we had suggested earlier on that maybe we start to have hybrid meetings and so on. But honestly, I think that this forum, this virtual meeting has been very useful and it's been able to connect everybody from all over the world. My personal view is that we should just continue with it and look for other opportunities. Continue with it as far as this monthly program is concerned, and then look for other opportunities where we can have physical meetings, maybe at PanConf or when we are strong enough, whenever, if we can have our own conference. These are just my views, but as usual, I will welcome suggestions in this area, which can be sent to me directly, or we'll continue the conversation on the platform of the group. So with those few words, I join Dr. Iletu in welcoming every one of us. And I would like to now hand over to Dr. Iletu to continue with the program. Thank you very much.
Thank you very much. Dr. Takom, over to you.
Thank you. Thank you, Dr. Iletu. I would like to thank my senior colleagues my teachers and the elders in the group for giving us this platform to actually be here to talk about something that's so important to us. So my role is just to moderate. Just a bit of introduction for those who don't know me. I'm Iyan Takon. I very much graduated, trained in Nigeria from Ibadan Medical School and Luz postgraduate before coming to the UK. So I'm pleased that I'm chairing for Kunle, whom I've known since toddler years. Kunle and I were in medical school together in Ibadan and kind of then, you know, continued here, continued in Luz and came into the UK. So he arrived here before me. So I've learned a lot from him and I'm sure we'll all learn a lot from him today. Kunle is a very experienced and senior clinician in this field. But one of the things that we're hoping to gain from today is not just the lectures, but looking for how we can discuss ways forward, because it's all about what we can do in our environment. And we know that there's no environment that is perfect, even here in the UK. It's not perfect. There's so many gaps, but we can look at what we have. How can we work together to improve things? So we welcome your suggestions and please put in any queries, questions you have in the chat, but we look forward to some stimulating discussions after Kunle's talk. So I'd like to hand over to Kunle now to give us his presentation. Thank you.
Well, thank you very much. I hope that everyone can hear me. I hope everyone can hear me.
Yes, we can.
That's fine.
Yes.
Yes. So thank you very much for the invitation. And once again, it's my great delight to see several of you that I haven't seen for many years, to see you live. And I'd also like to recognize my colleagues, my senior colleagues, people who have made an influence over one's career, and people who I can see and call mentors. I've chosen this topic this afternoon just for the purpose of not just being a bit provocative, but to also try to stimulate some discussion as we go along. I've posed a question, which I'm sure people have their views and perhaps have answered the question themselves already. So we can now take the opportunity to expand on that. Before I go ahead and do the screen share, I'll just touch on one or two very quick things. When we did graduate and qualify as doctors, one of the things we were introduced to at a very early stage was the Hippocratic Oath. And within that, there was that statement regarding, first of all, do no harm, which I'm sure we're all very familiar with. And there are little sound bites and nuggets like that, which we have all held to memory and hopefully hold dearly to. Sometime during my professional journey, I was at a conference and I heard a statement from a colleague, which has resonated with me for the past few decades. And that was regarding the role of us as doctors within the wider multidisciplinary teams. And the statement goes such that doctors tend to focus on, we tend to focus on healing people, on care. We are all about adding years to people's lives. But where the thing then changes, could people please mute their microphones if possible? Where the concept then changes is the fact that therapists and allied health professionals throw in their energy to add quality to life. So the contrast is that whilst the doctors are trying to extend the duration of the life, we've got other people working hard in the background to improve the quality of life for the patients that we see. And that resonates very strongly and hopefully will form the basis for our discussion this afternoon. I'm going to share my screen now. And I hope that everyone can still hear me. So the question is, we're talking about cerebral palsy. And the question is it purely a motor problem, or is there more to it than that? So I've got a quote here, which hopefully everyone can read along with, but it goes thus: that men ought to know that from nothing else but the brain comes joys and delights, laughter and sports, sorrows, griefs, despondency, lamentations, and by this is in a special manner we acquire wisdom and knowledge. We see and hear, we know what is foul and what is fair, what are bad and what are good, what are sweet and what are unsavory. And by the same organ, people become mad and delirious, and fears and terrors assail. All of these things we endure from the brain. So again, the brain is involved in so much more than just movement, but this is just a flavor of what it's all about. So this afternoon, we're going to talk about a few things. We're going to cover a few case summaries, hopefully to bring the whole wider picture together. A brief overview of cerebral palsy as a conceptualized diagnosis. And I say conceptualized, which I'll hopefully clarify upon later on as we go along. That just as we're talking about the epilepsies, the same concept can be applied to cerebral palsy, that it's not one unified diagnosis. It's very broad in terms of presentations, the etiology, and the different manifestations. We'll talk about the patterns and distributions of cerebral palsy, descriptive terminology, etiological descriptions, associated conditions or comorbidities. We'll give a little bit of intro into my local experience over here, and then we'll look to round up. This is a diagram which kind of indicates a few things about child development. And it's very simple and it's very transferable, and most people hopefully will understand it very easily. So the black line, which is diagonal all the way up, which states normal, it just shows a trajectory of what we expect in a typically developing child, a child who has got what we sometimes refer to as normal development. Then the blue line, hopefully it appears as blue on your screens also, which kind of curves up and joins the normal line. It just shows a typical or normal variation of what will still end up as being normal, but where the person's development can start off slightly delayed, but then there's good catch up later on. The third one is where right from the start, from very early on, from birth or shortly afterwards, the pattern of development has been delayed or impaired and stays that way throughout life. And that could be something where, by virtue of the nature of diagnosis, be it a genetic disorder like Down syndrome, or it could be another non-progressive disorder such as cerebral palsy, you can kind of expect that the pattern would be that there won't be any significant catch-up across all developmental domains to make them fit with the typically developing child. And the final one is the group which, as pediatricians, we always are worried about, and that's a group where children do show regression or degeneration in their global developmental or in an isolated domain of their development. In other words, it's not always a linear journey. And what we're looking for really is what is typical, what is atypical, is it progressive, is it non-progressive, and what can we do about it? Those of us who work within the field, whether it's in child development or neurodisability or neurology, we are aware of the fact that there comes a point where not only are parents comparing their child to other children of the same age, but also there's the global concept of what is typical and what is not. So as children do advance in age, they're expected to be able to walk and run and jump and climb and hop, write, feed themselves, dress and undress, talk, understand and learn, play and share, make friends, sit still when required to in structured time, learn turn taking, learn to comply with rules, show empathy, toilet themselves, and so on. And so being unable to do these at the expected ages or stages might suggest that there is a reason to be concerned. This could be a progressive condition or a non-progressive condition that is giving rise to that. So looking at the wider picture, we'll just try and get real about the whole thing. The fact that regarding our gross motor development and postural control and movement, which applies a lot to the concept of cerebral palsy, to be skillful in this requires intact vision. You need to be able to see, you need the neuronal pathways from the brain and all the way to peripheral muscles for you to adopt those skills to a reasonable degree. Within all of that also lies the sensory feedback and repetition. So as we continue to do things, we're also gaining skills, but also you get feedback in some form, whether validated externally or internally, and then the learning process can continue. For the fine motor skills, quite similarly, you need the vision, the neuronal pathways, all the way to the peripheral muscles and the sensory loop and repetition. For feeding to be effective requires adequate vision, good postural control, including the head control, fine motor skills and hand-eye coordination, chewing, safe swallow, and other sensory inputs. To enjoy our meals, without really putting much thought to it, we're smelling the food, we're tasting the food, we're hearing the crunching of things when there's something to crunch, including those juicy bones that we sometimes tuck into. And then there's a touch, the feel of it. Some people say that you haven't eaten or enjoyed the meal without really putting in some injection of love. And that's why certainly in a lot of Nigerian cultures, you enjoy the food when you eat it with your fingers. Now, I've just put something down here about just to challenge everyone regarding whether it's feeding or whether it's talking or breathing, that if you do not have that postural control in which you can keep your head control upright and also be in a posture that allows you to take in your environment, if you were to bend your head and neck over your chest and try to eat or try to talk or try to breathe at the same time, in some cases it is absolutely impossible to do, and in some cases it's very compromised. These are some of the challenges that our children with cerebral palsy do face on a regular basis, and thus postural control is absolutely important. Toileting. To be effective and safe and acquire skills at a typical age, again, the vision, the gross motor and fine motor skills, the ability to undress, sit on a toilet seat, rise safely, wipe self, dress, wash hands, and so on. And also with the adequate sensory inputs of wetness, dryness, the soiling, the smell. Anecdotally, I have had 2 children with very different and diverse backgrounds who have had the same problem, not my own biological children, 2 of my patients. One of them was a child who was obese. He was having problems with toileting and with lots of wetting. The other child had a form of bilateral diplegic cerebral palsy. He was mobile, he was intelligent, he also had a problem of wetting. What did they both have in common? They could not easily undo the buttons of their trousers. So even if they got to the toilet, before they were ready to do the business, simply undoing the buttons, they had wet themselves. So sometimes it's about making it easier for children to put on and take off their clothes, not simply the motor deficit per se. Speech language, communication and social skills. I have split it into all of this. Communication being different to speech and language because communication involves the non-verbal skills that support the speech and the language usage. So the eye contact, the nodding, the gesture, and so on, those are some of the non-verbal communication skills, and therefore even some of our children who might not be verbal would still or could still have the ability to communicate if that can be supported and facilitated. And that can include through non-verbal means such as sign language, of which there are many different types. But again, to acquire the skills of communication and use of speech requires intact hearing, good vision, to be able to mimic the way others talk and posture themselves, the motor skills, and so on. It also includes the muscles of the tongue, the oral muscles required for speech and swallowing of saliva and breathing coordination at the same time, which we're all doing subconsciously. Our children with cerebral palsy might not be so gifted, and so they might be in a situation whereby actually their tongue movements or the other oral muscles just are poorly coordinated, and therefore they drool a lot on their saliva. Some will nearly drown in their saliva. They have to breathe at the same time, and there are other aspects of the learning of the speech or of the communication skills which might be challenging. So I thought we'll just go through a few case summaries to make the case. So the first case is of a child which I've called AB, is a 6-year-old, uncomplicated pregnancy till term, and suddenly things went wrong. So during labor, there was an abnormal CTG trace, there was fetal bradycardia, and subsequently the child had perinatal hypoxic ischemic encephalopathy, was born at term by emergency cesarean section. APGAR scores remained low throughout, with the best APGAR score of 3 by 20 minutes. The child had developed early seizures. In this setting, was able to avail of therapeutic brain cooling, but in this case, things were so far gone that it didn't have an appreciable, it didn't make an appreciable difference or benefit. There was delayed onset of feeding. There was paucity of movement with early dystonic posturing and movement patterns, and subsequently child developed global impairment across all developmental domains. Was subsequently diagnosed with a 4-limb bilateral cerebral palsy. And I'll mention a bit about this whole bilateral and unilateral concept of cerebral palsy. And then the gross motor function classification score, GMFCS, which ranges from GMFCS 1 to 5, which I'll touch on a bit later also, did show that this child was very dependent in all areas of the mobility, and with continued spastic and dystonic features. Also developed severe non-progressive intellectual impairment, another term for a severe learning disability, and currently attends a special school. Has had epilepsy with multiple seizure types, has got tonic seizures, multifocal motor seizures, and epileptic absences. Is under a whole range of different professionals, including the neurodisability pediatrician, physiotherapist, occupational therapist, speech and language therapist, orthopedics, and so much more, as we'll see in a moment. Now, carrying on from there, the child has severe gastroesophageal reflux and has gone on to have a gastrostomy as a feeding tube into the stomach with fundoplication to reduce the tendency for the refluxing. The child had quite marked oral sensitivity, was not orally fed, had an unsafe swallow when that was assessed on video fluoroscopy, and is under the dietitian. The bowels, the intestines are not working well, has gastrointestinal dysmotility. A painful abdominal pain and bloating is an intermittent pattern, and there's also constipation. Is under another team, the gastro team, regarding the dysmotility. For feeding purposes, is on a blended diet and also some other special diet, which is also given via the gastrostomy. He has had recurrent respiratory symptoms, including aspiration, whether it be on saliva or feeds, retained secretions, and pneumonia. And one of the reasons why he's not being orally fed is to protect the lungs and the airway. He has persistent upper airway noises, and with stertorants under the ENT team. They have suction and oxygen saturation monitor at home. And again, the dietitian is monitoring the chronic poor weight gain. Now, the chronic poor weight gain, if you have got sustained tense muscles throughout, it becomes difficult for you actually, in spite of good calorific intake, to gain weight. So if I was to pump my muscles continuously through the day and through the night, it becomes hard for even on a good diet to gain weight accordingly. And then there are all the other problems of the respiratory problems and the different intakes. And it doesn't end there, because this child has bilateral painful dislocated hips, has had bilateral hip surgery, has scoliosis, which has been monitored by the spinal surgeons. When he's come in on an emergency basis, it's been nearly impossible to gain vascular access, and therefore has a central venous access through a porta cath. Has been under the ENT again regarding reducing the level of saliva. Has had some surgery regarding that. Has squints to both eyes and is being monitored in the eye clinic. Has had pressure sores in the past, which hopefully will be a thing of the past. And because the child has been quite thin, the tissue viability service has been involved, and the occupational therapists have provided equipment for this child to be regularly turned on the comfortable seats and comfortable bed. Has had a pathological fracture before, again because of low mineral bone density, and continues on vitamin D supplements and with intake from the metabolic bone disease team. So that just gives a flavor of how tough it can be for some of the young people that we look after. The medication list is not exhaustive: anti-epilepsy medicines, medicines to reduce the muscle spasm, also to reduce the amount of saliva being produced, so the hyoscine patch and the glycopyrronium. Is on laxatives for constipation, reflux treatment with domperidone and lansoprazole, pain relief with paracetamol and ibuprofen, sleep support with melatonin, and we sometimes also do offer respiratory prophylaxis with azithromycin given 3 times a week. Other interventions, we have the physiotherapist involved in the exercises and stretches, the wheelchair seating by the occupational therapist, the splints, orthopedics for the tendon releases, Botox with splinting and casting, and so on. So in this case, you've got a child who has got multiple impairments and who is living under a household, and even a super parent will be exhausted with the amount of input that is required to support and nurture the child going forward. The second case is of a child of a similar age who was born prematurely at 26 weeks gestation, required ventilatory support for neonatal respiratory distress syndrome, had some of the common or not uncommon problems of premature birth, including low blood pressure, the blood pressure swings following the persistent ductus arteriosus, subsequently developed bilateral intraventricular hemorrhages, and then hydrocephalus, which was then shunted with a VP shunt, and then subsequently developed bilateral periventricular leukomalacia. This child spent 3 months on the neonatal intensive care unit, had chronic lung disease of prematurity, and was oxygen dependent throughout that period. Was a late walker, not walking until about 3 years of age, and with an asymmetric toe walking pattern. Was subsequently diagnosed with bilateral spastic cerebral palsy, mainly affecting lower limbs in a diplegic distribution, this time with a GMFCS score of 2, different to the fully dependent non-mobile child we talked about earlier on, who had a GMFCS of 5. In contrast, this child attends a mainstream school, though with some mild element of learning difficulties, has good language and communication skills, can dress and undress, but given the lower limb difficulties, is occasionally challenged with toileting, but overall is doing quite well. Management is much less complicated, has physiotherapy, has splints to the lower limbs, the ankle foot orthosis splints, and is on oral baclofen to reduce the muscle spasms, which can be painful and uncomfortable at times. But otherwise, the child is doing really well. The third case, and the final one of the three, is a 6-year-old who full-term birth following an uncomplicated pregnancy and seemed well, but on day 2 of life was noted to have some right-sided focal motor seizures. Had an MRI scan which showed an infarct to the middle cerebral artery territory. And the pattern later evolved into clear features of a unilateral or hemiplegic cerebral palsy affecting the right side. This child, again, is doing well with normal intellect, speech, and behavior. Independent performance of activities of daily living are being undertaken by the child, and with low-level physiotherapy needs other than splints to the right ankle. The child is not on any medication. So here we've got 3 different children, very varied. They've all got the same diagnosis under the same umbrella term of cerebral palsy, but are they the same child with the same diagnosis? Does it mean the same thing? I would challenge that perhaps we should be talking about a cerebral palsy spectrum condition rather than a simple umbrella term where people think they understand, but forget the level of comorbidities and other implications for the child. So when we were in training, what we were told about cerebral palsy was that it was a disorder of posture and movement due to an insult to the developing brain. Times have moved on, and there's been a concerted attempt to update on that diagnosis. And now we're talking about it being a group of permanent disorders of the development of movement and posture, causing activity limitation that are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain, and that the motor disorders of cerebral palsy are often accompanied by disturbances of sensation, perception, cognition, communication, and behavior, and also by epilepsy and secondary musculoskeletal problems. So this definition, which has come about from the European and the American groups, expands on our thinking and understanding of cerebral palsy, and therefore the amount of input that should and would be required for many of the young people that we look after. I won't say very much regarding this slide, but we do know that the premature or immature brain is more prone to insults around the periventricular area, resulting not uncommonly in periventricular leukomalacia and the pattern of diplegic cerebral palsy. This is different to the term baby, who an insult at those early stages, particularly with oxygen starvation from any hypoxic insult or traumatic insult, would often affect the cells of the basal ganglia with a different pattern to the premature baby. And these ones then end up with spastic dystonic bilateral forelimb cerebral palsy. So there's a wide variance in terms of the patterns of disability and etiology and associated conditions. We generally talk about cerebral palsy as being a condition, and certainly in the UK, prevalence has hardly changed over several decades, about 2 to 3 per 1,000 live births. And this includes the fact that since we have been looking after more and more premature babies, we are having more of them with different patterns of motor impairment. But in spite of this, the overall prevalence still remains about 2 to 3 per 1,000. There have also been some good studies in Nigeria where they have looked at different prevalence rates and also comorbidities. Most of these have been, I know there's one, there have been from Kano, from a group in Ogun State, in Lagos, Ibadan at different times. Most of these have looked at tendencies to the neurology clinics and not so much of population-based studies. So the management goals, we're looking at limiting the impairment or disability, which is already developed and is non-progressive. We should be anticipating the fact that there is likely to be additional issues or concerns, and to treat these and as they emerge during our ongoing surveillance. And then there's the issue of how do we classify the impairments. So some of you may be familiar with the gross motor function classification score. Some may be less familiar with it, but again, it's classed from 1 to 5, from the completely independently mobile child who is at level 1 to the fully dependent, the child who is non-independently mobile and requires wheelchair for mobility, and also needs support for head control and body posture. This is a little diagram of what the GMFCS is all about, and with the GMFCS level 1 at the top and level 5 at the bottom. In the interest of time, I won't go through all of those, but simply from the picture, I think it speaks for itself. So regarding cerebral palsy, over the years, the terminologies have changed, and although we still use the terms hemiplegia, diplegia, quadriplegia, but the preferred terminology now is to talk about unilateral cerebral palsies, which are the hemiplegias, and then you've got the bilateral ones, which are the diplegias and the quadriplegias. Then there's a concept of the pattern of tone, whether it's more of a spasticity pattern or a dystonic pattern or a mixed pattern. Now, again, because the emphasis of today's talk is not so much on the patterns of cerebral palsy themselves, I won't dwell too deeply on these, but just to bear in mind that about 30% of the spastic cerebral palsies will be unilateral and about 6% bilateral. A lot of it will be mixed with a dystonic pattern. You don't always have very pure spastic or pure dystonic, except in a few selective groups. But the dystonic ones are usually due to basal ganglia damage and form 7% of cerebral palsies. The ataxic cerebral palsies are very rare, and I don't think we've got any case of a clear ataxic cerebral palsy on our caseload. So functionally, we're thinking about the weakness, the poor selective motor control, and the impact of these in addition to all the other conditions that we can think about. For the bilateral spastic cerebral palsies, 2 out of 3 will be unable to walk without aids at the age of 5 years. Contractures are common. We can anticipate those and get our physiotherapists, our orthopedic colleagues to intervene at an early stage as appropriate. Hip displacement also common and also painful in about 56% of the cases. Now, the non-motor comorbidities for the bilateral spastic cerebral palsies, a third of them will have epilepsy, including 10% with West syndrome. Learning difficulty and learning or intellectual disability, we look at those as being different entities. The learning disability or intellectual disability or intellectual impairment are those who have a low IQ and will not, it's a non-permanent situation, and they will not have the ability to cognitively to function at a typical level. The learning difficulty could be someone who's got a specific learning difficulty, things like the dyslexias, the dyscalculias, and so on, or who might have a mild general learning difficulty. For those who have got a diplegic cerebral palsy pattern, 20% will have a learning difficulty, 40% will have a learning disability. But of this group, 40% of the diplegic leg-dominated cerebral palsies will have normal intelligence. And so the whole idea that people see a child who has got an unusual gait and feel that cognitively the person is not smart, I think there's good evidence from the literature that goes against that. Severe cerebral or cortical visual impairment is seen in about half of the children who will be classed as being blind in the severe group. And although there are smaller groups who would have very good vision indeed. Deafness is seen in about 3%, and drooling of saliva, which we might not look at as being a very serious thing, but if you drool, it becomes difficult to, in terms of the ability to swallow and maintain that and protect your airway in order to feed also, and just simply the cosmetic appearance, that can be very problematic. The clothes get wet and soaked, again, it's an issue. Up to 3/4 can have that as a problem. We've talked about the gait already. In unilateral spastic cerebral palsy, more than 50%, more than half can walk without restriction. 10% will have a severe limp and 30% somewhere in between. And then you've got the hand function, which can actually be quite good in about half of them. In the hemiplegic or unilateral spastic cerebral palsies, learning difficulty or intellectual disability is much milder, up to 30%. And then the visual problems and sensory problems also can prevail. So when we're talking about the sensory problems, we're talking about things like difficulty with managing cold and warmth, or mottled hands, or pain or tingling or other discomforts. So other co-occurring problems: communication difficulties, behavior difficulties, sleep problems, mental health disorders, ADHD, autism, and other neurodevelopmental disorders, constipation, and the list goes on. So I'd like to thrust in here the fact that it does require a large team effort to support the child and family who has got significant cerebral palsy, with a range of different specialists that they would require in a setting such as where I am in the UK. So the management strategies would include management of posture and mobility to treat the comorbidities, the reflux, the drooling, the feeding, the communication, and all the things we've talked about, and not to forget pain and discomfort. Sleep issues, sensory issues, emotional well-being, participation in society, very key. So think child, think family, think siblings, think respite care, think end of life, and think hospice for the severe ones who will have life-limiting conditions and will not or may not live till adulthood. So our experience locally, what I tried to do is have a very quick look at our database locally and to see what our pattern was and compare it to the literature. So we had about 130 children on our Cerebral Palsy Integrated Pathways CPIP database, which gave us about 2.3 per 1,000 children between 0 and 16 years of age. And we had to rule out, when I did have a quick look, just looking through their hospital letters, ruling out progressive conditions that would not fulfill the diagnostic criteria. CPIP is managed by our physiotherapists who would monitor the hips and spine and other essential things that could need early interventions into, particularly orthopedically. They request the x-rays and all by themselves, and then within the multidisciplinary team, we'll discuss and review them. We've got a performer that we adopted from, which is different to the CPIP performer, but one that I adopted from one that I saw in the British Association of Childhood Disability and Community Child Health magazine from 2019, which does highlight a range of things that we need to think about in these children and young people. And The next slide, which hopefully you can see better, does highlight the things that if you don't think about them all the time, you might not remember to ask about them or to anticipate that there could be problems with them. In our group, we had 57% were males and 43% were females. The pattern of distribution was actually quite similar to what the literature does say. We had about a quarter being hemiplegic. We had diplegia being about just under half at 42%. Most of these were related to premature birth. And then we had other patterns, the severe forelimb cerebral palsies at about 20%. Mapping it with what we expect from the literature, in our case, we had 63% were bilateral. Literature says it's about 60%. Our hemiplegia was at 26%, literature says 30%, and our dystonic CPs were at 9% versus 10% in the literature. So what were the associated conditions that they did have? Hip dysplasia, scoliosis, global developmental impairment, deafness, dyslexia, microcephaly, gastroesophageal reflux, speech language difficulties, continence difficulties. One had a gastrostomy. Epilepsy in a quarter, autism and ADHD, learning disability, learning difficulties, visual impairment, including squints and amblyopia. Now, the one thing that was hardly addressed, which was not that we're unaware of it, but it was again a bit of an eye-opener, was that mental health problems and needs were not always recognized, they were not always documented, and they were not always being supported. So this slide is from our Learning Disabilities Child and Adolescent Mental Health Service, and I got this from them, and they've seen that low mood is something that they do see in those who have sleep difficulties and pain and constipation. Self-esteem issues and anxiety are also problems that they do come across. And the common theme is that about challenges when attending to personal care, their engagement with therapies, anxiety about separation and sleep difficulties also were a problem. So all of this linked to the cerebral palsy itself, the learning disability, and the behavior. So I'm going to speed up a bit because of time, but some of our etiological associations were premature birth, as mentioned, congenital CMV, cytomegalovirus, genetic disorders, hypoxic ischemic encephalopathy, meningitis, traumatic brain injury, and thrombocytopenic brain injury. It's interesting to note that we had 0 cases of kernicterus, and I haven't come across a single case of kernicterus during the course of my practice in the UK. MRI findings were again quite variable, with brain abnormalities picked up, some incidentally and some that could be anticipated, such as the periventricular leukomalacias. We had middle cerebral artery infarcts causing hemiplegic CPs, parencephalic cysts, sort of kind of an extension from the ventricles, and those who have cystic encephalomalacia. We had a range of GMFCS scores, of which most of our cohort were in the GMFCS 1 or 2 group, and only very few were at the more severe end of the spectrum. So from our Chesterfield pattern using our register, we found that the pattern was quite similar to that of the literature. Premature birth was a significant contributor and resulting in a diplegic pattern in most of the cases. Majority fell within the 1 or 2 GMFCS levels, and several comorbid conditions were identified. So just to summarize what we've talked about, we've gone through case summaries. We've talked about cerebral palsy as a conceptualized diagnosis. I would argue that it's not a single diagnosis, but an umbrella term that encompasses a range of different etiologies, different impairments, different severities, different comorbidities, and different prognoses. We've talked about the patterns and distributions of cerebral palsy, descriptive terminology, now adopting unilateral and bilateral, and descriptions of the etiology as best as possible, because this is what helps us more prognostically to prognosticate their futures. Associated comorbidities and the broad management principles. And I've shared with you some of our local Chesterfield patterns and experiences. We've talked about the aims of treatments to manage the posture and movement, thinking about pain and discomfort, offering equipments and aids and adaptations where necessary, treating the comorbidities, thinking about nutrition and feeding and growth, communication, vision, hearing, and so on. Sleep issues, sensory issues, quality of life, and participation in society, if not given a chance, will still be in yesteryears where they will all be condemned, when they do have the potential to enjoy life, and in some cases for the milder ones to show some participation at a normal level. Think about the education. Again, think child, think family, think siblings, think respite, think end of life, and hospice, if and when it ever was required. Thank you very much. I'll end the presentation and the slideshow there. I'll take questions now, if there are any.
Thank you. Thank you very much, Kunle. I think we will all agree, and I think we should all give him a clap from wherever we are, because that's been a fantastic overview, very comprehensive, very, detailed, it was fantastic. Thank you so much, Kunle. And your summary slides have gone through everything, in the way that we've all been able to understand and follow. I just want to take some of the questions, but in the comments, but I think one of the things that struck, one of the taglines you've used, which I can relate to one of the patients I have, is where if we don't do anything, these children will be relegated to the background. And I was very pleased when one of my cerebral palsy patients actually became a Paralympian champion for swimming, and she took that up from physiotherapy, where she was having physio and she was doing these swimming exercises, and she actually competed in Japan, and she became one of the champions. So there's so much that these children can achieve, and it's just wonderful when we put all our energy in trying to help them. But we realize that there are barriers, and I think this is where we need to have some discussions today following your brilliant talk, is what can we do? I'll first of all go to the questions, because there's been quite a few questions. Dr. Nifade has been typing away. So first question is, could you differentiate between learning disability and difficulty, Kunle? That's Dr. Nifade's question, to differentiate between learning disability and difficulty.
Okay, I think I partly explained for that earlier on, but the concept of it is that when we talk about a learning difficulty, it can be either an isolated or specific learning difficulty, which encompasses a group of individuals, adult or children, who have specific conditions, like dyslexia is a specific learning difficulty, dyscalculia with numeracy, those are learning difficulties. Then you've got some who might have a global learning difficulty, just that they have to put in a bit more effort to learn, but they are able to do reasonably well enough with support and guidance. Those who have a learning disability, and hence the more recent concept of referring to it as an intellectual impairment, focuses on their IQ, that they have a low IQ, and this serves as a barrier to their ability to learn. That's the difference. And so those who have got learning disabilities, particularly moderate or severe, with low IQs, are the ones who, in the concept of the UK population, for instance, might be in the special schools, whereas those with the learning difficulties are likely to be in mainstream schools. That's what I mean.
Okay, thank you. Second question, your patient AB, I think that was the first case, had fundoplication and gastrostomy, but yet went on to have medications for gut mobility. At what point would you consider gastrojejunal feeding, and would it help with reflux?
Okay, that child had gone on to have what we often see, what I see in my practice is that you have individuals who feeding becomes a significant event in the life of the family and in the life of the child. So you have individuals who it could take up to 1 hour, sometimes longer, just to get one feed in. And with all of that, there can be choking and spluttering and aspiration into the chest. At some point, it's recognized that the feeding orally is unsafe, or that the ability to take sufficient intake is not going to happen, or that the features of the reflux is becoming too problematic. And at that point, consideration for alternative feeding methods, such as insertion of a gastrostomy, should be entertained in a timely manner.
Okay. And also, would ataxic CP, would it not be really common in Nigeria? Would this be common in Nigeria?
I don't think that it's going to be common in Nigeria. I think that from the pattern, from my experience of working in, of being a medical student in Ibadan and being a resident in Lagos at Luth, that the pattern of what we were seeing was more related to either birth asphyxia, in other words, hypoxic ischemic encephalopathy, or alternatively, those who had suffered from hyperbilirubinemia in the context of kernicterus. So what we're seeing was either a pattern of basal ganglia damage from the kernicterus and also from the birth asphyxia, or in some cases, we were having some children who were having typoplegic patterns, but because we didn't have a population of premature born children, we're having less of the periventricular leukomalacia and less pure diplegias. I don't recall seeing many ataxic forms, and some of those are wrongly attributed to cerebral palsy.
Okay. And the last question from Dr. Nifade was were the mental problems in the patients or the family members?
The emotional problems, the psychological problems, the mental health problems we're referring to in the children themselves, in the young people themselves. But that doesn't say that for any individual family unit who's going through such a challenging time with a child with significant difficulty, that's not to say that it does not breed its own emotional health and well-being and mental health difficulties for the parents and carers. And this also shouldn't be ignored. And hence the concept of respite care, just the opportunity to have a breather away from just being a full-time carer. And that's one of the important aspects to be thought about also.
I just want to add that sometimes we have had to ask some of our parents to get help from their GPs, because it can be quite overwhelming having a lot of people coming into your house or going in and out of places, taking the child. It can be quite overwhelming. And we've had some parents who've actually suffered significant depression as a result of that. So it's, I would say, just like Kunle has mentioned, both in the child and the family, we should be looking at that. So thank you, Kunle. Then there's a question.
Can I just come? I think it's a hidden need. It's poorly recognized for the young people, and it's poorly recognized as a need for the carers and parents also.
Yeah. Then there's from Zainab, who saying thank you for your talk, and she's mentioned, she noticed you use the word suspected CP. How early is the diagnosis made, definitive diagnosis made in the UK?
In my experience, I feel that we should, if there is sufficient either background history, developmental trajectory, and also physical signs, we should feel emboldened to have those discussions at an early stage enough with the families. Most of the time, the features of an evolving or manifest CP, by about 6 months, you have a good idea that this child has got cerebral palsy. People feel uncomfortable about it, and most of the time it's because of that whole the connotation of a diagnosis that seems so weighty. It's sometimes hard for people to feel that they are, in a sense, killing off the joys and dreams of a family regarding the birth of their child and the aspirations and dreams that they have for the future. But if we get in early and are able to share of our concerns, and at the right time, at the right stage, different families are ready for a diagnosis at different ages and stages. And you have to respect that. It's not about forcing a diagnosis down anyone's throat just to make them aware that there's a problem. So I wouldn't say there's a fixed stage or age that we would be given a diagnosis, but I think it's something to consider the best early timing to share the diagnosis, to assist the child to get the best care, and also to help the family to plan the ongoing care for the child.
Thank you. Which medications have been helpful with dyskinetic movements in children with dyskinetic CP?
A lot of medicines, it can be quite frustrating. A lot of medicines may not have the benefit that might be thought about. Things like trihexyphenidyl, which is given some people might try things like gabapentin and other medicines. A lot of those may have a very mixed picture. For the spastic and for the spasticity, baclofen is good. Diazepam is good, but again, they've got side effects of sedation. You can overdo it with them. So you can give a medicine that reduces the muscle spasm, but it reduces muscle spasm globally. And therefore, what you are gaining in some respect, you can lose, for instance, in a child suddenly becoming floppy in neck control, which becomes an issue also. So there's no medicine that I would say is perfect. There are now more recent deliveries where those who have got severe spastic cerebral palsy, the GMFCS5, some of the GMFCS5s, some of them are now having intrathecal baclofen so that it spares the whole body and the whole system being exposed to side effects, and it targets it through giving it into the CSF space.
Thank you. And somebody has asked you, I want to know if the terminology hypoxic ischemic encephalopathy is interchangeable with neonatal encephalopathy.
I would say yes. I would prefer to use the term perinatal hypoxic ischemic encephalopathy. And in some cases, if it happens later on in life, for a child or an adult, it could still be a hypoxic or ischemic event. But again, to be careful, that we've moved to a large degree from the term birth asphyxia. And also, when you call it neonatal HIE, it sometimes does not take into account the fact that perinatal, including prenatal factors or the factors during labor and birth itself might be contributory. So it's not always neonatal onset or neonatal insult. We have to take into account the perinatal or antenatal nature of it. And that also should be taken into account for medical legal reasons, which might not be big might not be too big in Nigeria at the moment, but in other parts of the world where people think medical legally, you have to be careful in how you define things, or it can come after you.
Yeah, someone would ask, what would explain the absence of connectors in Chesterfield? And is there any current simpler definition for cerebral palsy?
Thank you. Another very good question. Like I said, the main the children that we were seeing, certainly when I was working and training in Nigeria, was that the burden of connectors was mostly from, well, exclusively, even as the term goes, it's from those who have had significant levels of unconjugated hyperbilirubinemia. Now, over here, because of things like all the the anti-D injections that are being given, and then you can anticipate where there could be a risk. So you mitigate against that risk maternally, so that you then don't have a child who's got a significant hemolytic burden when they're born. In those who either expectedly or unexpectedly who have a high bilirubin load, early intervention, early recognition, prompt treatment averts connectors in most cases. And perhaps there are different etiologies. We don't have so much of the G6PDs over here. Where there are Rh negative people, that's usually taken care of by the anti-Ds. So in most cases, we don't. There have been studies done across the UK, and connectors is extremely rare in the UK. And the very few cases, I certainly in one of the surveys that was done, the very few cases, certainly maybe under 10 in the whole of the country, were more due to children who had been had poorly established feeding of whatever type, and was accounted for by severe levels of dehydration, maybe with or without some other contributory factor. So it wasn't oftentimes a pure hyperbilirubinemic picture. Now, not to say that there won't be some cases where where it's aggressive enough, but it's not common. And when it is recognized, treatment measures are instituted very early on. And again, it's something that anyone who works within a system such as this, aside from caring for the child, connectors will be big money in medical legal circles.
Okay, so then Dr. Uwaje has asked I think one of the questions that should stimulate discussion. She said, what has the Nigerian experience been, and how can we assist for those of us practicing in Nigeria? And I think this is one of the questions that I think we need to have some discussions about. How can we, what can we do? So we've seen, what the impairments that happen, and we can see that the children with cerebral palsy have to have services from so many clinicians. They go to, if you think of any department in the hospital, a child with cerebral palsy would likely visit that department just from your list. So how can the pediatrician who is working in, say, Luth or any of the other hospitals, how can they help this child with all these things that you have presented and all these services, the child, knowing that our resources are limited, we don't have, as many resources, therapists are limited. What do you think we can do in terms of beginning to look forward for the children with cerebral palsy in Nigeria?
Okay.
I don't know whether there's anybody that wants to kickstart that discussion. I know we don't have too much time, but I think this is the crux, that after this very lovely presentation that you've given us, we have to practice in Nigeria. What can we do to help the children?
I can kick the ball rolling. Okay, I can see Dr. Dosakun's hand up, but I can get the ball rolling from the point of view that we have to remember that some of the cases are preventable. So if we go back to one of my very early statements, that first of all, do no harm. If there are situations where we can mitigate against, first of all, do no harm. Let us prevent what is preventable. And there'll be some cases where there may not be much that we can do, but anticipate the problem, have a pattern of ongoing surveillance whereby we can pick up where there are problems at an early stage, and the system in whatever form, and I say this as someone who is removed from the system at the moment, to have some mechanism that recognizes that it goes beyond just being a movement problem to a to multiple impairment, multiple ability problem that needs tackling. I humble myself to my colleagues in Nigeria who practice in Nigeria, and who would have a greater expertise in responding to this question. So perhaps Dr. Dosakun wants to provide some insight.
Yeah, Dr. Dosakun, please, can you unmute and give your contribution?
Yes, sir. It's wonderful talking about this. I'm so glad we're talking about this very difficult problem that has input not only from the health, from education, social, mental services. And in Nigeria, we have to think about poverty, elevation, women empowerment, because there's just no social system that's supporting these parents. There's actually very, very little being done currently in the field of managing children with cerebral palsy. Like you said, we should try and prevent all those conditions. We should go crazy in preventing conditions. We need to have a very structured follow-up program for graduates of the neonatal care. And I think this is one of the areas where there could be a public-private partnership. There are lots of private pediatricians on this platform. We should be able to work in some way with government in following up all the children that go through neonatal units. There's a very important thing that has come up now in learning now, is that the brain grows. And if these children are picked up early and given adequate stimulation, opportunity, and frequency, we may be able to modulate some of the damage that has occurred in the brain. Another big area is getting the parents to self-help themselves, because there's no health financing, there's no universal health coverage, it's out of pocket. So I think, we need to start thinking of setting up child development units, and where we assess these children, we get the parents into groups, maybe according to the level of severity, and they would have to learn how to support each other, because the system is not supporting them and not supporting the vulnerables. And if we do have these units, we can work with their schools. The schools these children go to, most of them go to integrated schools, because there's a lot of denial. There's nothing wrong with my child. And we as pediatricians can support that system, giving advice on what to do to support movement, to help with posture. It is a very sad situation. I will just give you a little insight. The outreach group, that's my hospital group, is thinking of going into neurodisability. And we had a camp. We had a camp for children with cerebral palsy. Within 48 hours, we had 400 calls. Most of the parents were very annoyed. We've done nothing wrong, but they were very annoyed with the Nigerian health system. Some were even abusive. Some were from states very far from Lagos. And, they criticized us and said, "You are very stupid, having a course in looking after cerebral palsy in Lagos. Lagos has hospitals. We have nothing. We just have these children, nothing for them, So we could already feel the pulse of the people, They were very annoyed and very depressed. And we were only able to assess 98 of them and promise them that in a few months' time, we'll come up with some semblance of a neurodisability center. and they have kept on calling and putting on the pressure. You know, it's they are left all on their own, and their parents, you know, just can't cope. So it's a very sad situation there, you know, with parents almost at the brink of suicide. So it's a very neglected area. This is an area that I think the pediatricians, private pediatricians, can come together and develop, you know, some semblance. It might not be as integrated and as comprehensive as it is in the developed centers, but I think if we allow these children to be picked up early by working on government for some formalized system of child health surveillance, so we get them early, we follow up the children who have left our units. You know, even if they don't come, we have a home care team that would actually go and see how these children are doing, so that we can start early intervention in all the domains.
Thank you. Thank you very much. Dr. Nifade, I can see your hand up.
I just have, I think Dr. Dosekun said, approaching the problem by a two-pronged approach, you know, from the healthcare healthcare practitioners, and then the parents' point of view. I'm just going to say from the healthcare practitioners' point of view, we need a lot of collaboration. We have to learn to collaborate. That's the only way we can make these things work. Apart from collaboration, we have to develop care pathways, which was exactly what she was saying. Develop a care pathway where every doctor, every pediatrician is aware that this pathway exists and the patients can be taken through the pathways. And finally, rather than just have a neurology clinic, we have to have a clinic for children with neurodisability. Those three C's are important: collaboration, care pathways, and clinics for children with neurodisability. We can start that. Those parents have so much burden to carry. You know, have one child. I have a disabled child, so I know exactly what it feels like to look after a child with disability. It's a massive burden. The money you spend going to physiotherapy, looking for equipment to help the child, it's not easy. So carrying that burden to the family, I think is asking for a bit too much. No wonder they were angry, you know. I don't know how we can
comment also.
Yeah, I don't know how we can involve the government, but as pediatricians, we can try our best. Thank you.
Thank you very much.
If I may just pass another quick comment, which part of it might seem more theoretical or hypothetical because it doesn't have much meat or substance on it until it's packaged together. But one of the things that I learned very early on in my pediatric journey, and I think it was from either Jolly or Jelif, the pediatric books that we used to use, when they were talking about introducing change or introducing services, they talked about education as the first thing. They talked about environmental modification, you know, so all the aids and adaptations and so on that we're talking about to make things easier for the young people. Then there's also the whole concept of, you know, trying to introduce something through some form of enforced legislation. And then the final thing is empowerment of the young people themselves and the families. Now, it's no wonder that everything that the four things I've mentioned, they all start with E's. So it's the 4 E's: education, environmental modification, then we've got the enforcement by legislation and the empowerment. So whether that's got to do with introducing change or whether it's got to do with safety measures or otherwise, those would be the 4 principles in my mind. And the latter two, the empowerment and the legislation, enforcement of legislation, I think those would be the most powerful tools on the longer term, whilst education and environmental modification carries on in the background.
Thank you, Kunle. And I just wanted to add that I think for a couple of years, I was coming to Ibadan and doing some teaching, and which took me to the neurology clinic and took me to centers where children with disabilities were. And it was quite sad. You were almost hit by the burden of the problem. And one of the things then was that you asked where the therapists were. The therapists were completely in a separate unit and were not linked in with the clinicians, and there were very few. So in the hospital there, as big as UCH was, had only one speech and language therapist serving the whole hospital. And these were patients who were coming from other places as well. So we know that we can't do it alone as clinicians. So we need to form partnerships with our allies in how can we increase capacity. We have to devise something that is probably suitable for our community. So we're not going to get expert therapists and expert physios. What I learned here is that the physios have the therapists have a lot of assistants that they train that work with them and in turn help to deliver some of these therapies. And those assistants work with the schools. So Efumbo raised a very important point about schools, and schools are great allies in partnership in supporting children. So we need to start looking at other models. There's so many young people without jobs. How can we retrain them to be part of this skilling up? And if they're working with senior therapists and who are linked in with the clinicians to develop skills to actually help support the children that need this, we need to be looking at those models. We're not going to be able to get the number of therapists we need to go through the degrees and come out with the qualifications, but we can train people. They're hands-on activities. We can train, we can look at models of training other people, and we should work in partnership. So Dr. Nifade has suggested running clinics with involving other people. We need to know that we can't do this just as clinicians. So partnership is one of the things I want to put in. How can we build that partnership? How do we know what the physio is doing? Do we know whether the physio is delivering the right kind of therapy, and what level, how up to date are they with the education? So education comes back there, that we all need to be educated to make sure that we're doing things for the improvement of the quality. So there's quite a lot to think about. But I think that unlike myself, that I got thrown back because of the burden and the sheer magnitude of how big the problem was. But I think we need to start going down and saying, how can we help? Because even here in the UK, we don't have enough therapists. We don't. But what they do is actually transfer those skills to other people who are there, teach the parents as well, teach other people who in turn continue to support the children. And I just wonder whether there's other comments from any other person, but I think it's been really useful discussions that we've had. I also feel that our organization as PAN need to be in the forefront of advocating for children with disabilities. How can we as PAN make this in the forefront as well? We need to, bring up that advocacy, working with the government, because it's something that affects here the Royal College and, the pediatric forums are very strong on advocating. We need to be looking at that for a PAN in Nigeria. So it's been a great afternoon. I think we've learned so much from Kunle. Thank you so much. And we've had very interesting discussions. I'll hand over to, is it Dr. Eletu?
Iyanga, chairperson, wants to speak.
Oh, sorry.
His hand is up.
Oh, sorry, Doctor.
Yes.
Okay.
I'm so sorry.
Yes. Okay, well, thank you very much. I think the moderator just got to where I wanted to start from. I want to thank the presenter for a very excellent presentation, and also the comments, the local comments from Dr. Dosekun and Dr.
Dr. Nifade.
Oh, they're getting
Elizabeth.
old.
You
Dr.
know,
Nifade.
Dr. Nifade, I'm sorry. Yeah, because you have more or less defined what we need to do locally. And nothing pleases me more today, that's why I was raising my hand, than to announce to everyone that we have amongst us the president of the Pediatric Association of Nigeria. The new president of the Pediatric Association of Nigeria. I interacted quite a bit with him at the last conference, and I'm very happy to welcome him to this gathering. Dr. Femi Ogunrinde, Professor Femi Ogunrinde from Zaria. I hope you can hear me.
I can, sir. I can hear you, sir.
Okay, I'm very, very happy to welcome you here. It's a great pleasure to have the president of Pediatric Association here with us. A big ball has been thrown in our court as Pediatric Association right now, and you know it's very auspicious that you are here with us. I was going to ask you before to just give us a word or two of encouragement. I will still do that, and also ask whether you have something to say about this issue of you know, how can we collaborate more and develop care pathway, you know, collaboration. And the clinics for neurodisability and general advocacy, as has been suggested by our moderator in this regard. If I can crave your indulgence, everyone, this meeting has gone on for longer than usual because of it's so interesting. Normally, we like to close at 4 o'clock, but please grant me a few minutes to, it's not often we have the president of Pediatric Association with you for us to hear a few comments from him. Over to you, Professor Ogunrinde.
Thank you very much, sir, for this introduction. I'm also very happy to be here today. I actually attended some of your previous meetings, even though I was not, I was just president-elect that time. But this has been a very interesting presentation by Dr. Ayonrinde. I was so impressed. A lot of refreshing of my knowledge. Even though I'm not a neurologist, but I still gain maximally. Yes, I heard when the call for PAN advocacy was made. Of course, that's one of the major aims of PAN. And I'm also happy to say that it was at the last conference that this forum, the Pediatric in Private Practice, was more or less inaugurated, at least with PAN. So we actually intend to work with all our subspecialties because I think PAN is no more a general pediatric affair. We are going to be depending on our subspecialties to move along strongly, to bring our full weight to bear. So we'll be working very closely with PIPP in advocacy for the Nigerian child. Thank you very much, sir. Over and out.
So Dr. Eletu, please, over to you back.
Thank you very much, sir. Femi Ogunrinde, that was a very diplomatic answer, but we understand. We'll talk offline, and then I'm sure, like you told me, you will do a lot more for children in terms of advocacy. So we'll expect your group will do that. Just before I hand over to Dr. Odudu, I want to say a special thank you personally to Dr. Ayonrinde, because I remember when I called him about 4 months ago that I would like him to give a talk. He assured me he was going to do that, and he was ready with his presentation over 2 months ago. In fact, he did his simulation with us 2 weeks ago. Usually we would like to do the simulation a day or two before the presentation, but he was far ready for us. So, Kunle, thank you very much. Anyway, I didn't expect anything less. For Yang, I called you just a few days ago, and you took up the mantle, so thank you very much. Just to put you on hold or notice, you will be presenting very soon. So start thinking about your topic. So I'd like to hand over to Dr. Odudu to say to give the vote of thanks, and also to remind everybody that the next presentation is on the 24th of February. The presenter is ready as well. And you will be seeing the poster very soon. Thank you very much. Dr. Dudu, over to you.
Thank you very much, Sam. There's no gainsaying that we've had a very rewarding evening, afternoon from this part of the world. I just want to join everybody in thanking our presenter, Dr. Ayonrinde, for a very lucid and very informative presentation. We've learned quite a lot. And we also want to thank our moderator today for our next part session. She has moderated so well and given lots of information that has been quite helpful. And we're always encouraged to have our very senior colleagues participate in these meetings, also making very useful contributions. We're indeed very grateful. And we cannot but mention especially our father, Ageni Fuja, for his encouragement. He was quite early in logging on to this presentation. Not to overlook the effort that has been put together in bringing this session together. Dr. Iletu and his technical crew, we are indeed very grateful. So we look forward again to the next presentation next month, and we are all hoping that it will be as stimulating as this as well. So thank you very much, and have the rest of the day. Thank you very much.
Thank you very much. Hope to see you on the 24th of February. God bless.
Okay.
Thank you, everyone. Bye-bye.
Thank you.